Welcome back, everyone. We're now going to start talking about the direct diuretics, and in this recording, I'm going to be talking about the loop diuretics. So here's your detailed learning objective. It's to be able to describe the major classes of pharmaceuticals that are used to manipulate the urinary system to alter blood pressure. And here we're talking about loop diuretics. So diuretics are drugs that will increase the production of urine. So by increasing the production of urine, will this increase or decrease blood pressure, and why? I think everybody in the class will know the answer to this. Diuretics will decrease blood pressure because by increasing the volume of urine that's produced, that will decrease the blood volume, and blood volume is directly related to blood pressure. So a decrease in blood volume will therefore mean there'll be a decrease in blood pressure. So diuretics increase urine volume by decreasing water reabsorption from the filtrate back into the blood. And diuretics decrease water reabsorption by changing the osmotic gradient. So which solute then has the biggest impact on the osmotic gradient within the body? And I think, again, everybody would get the answer correct there in terms of sodium. So most diuretics will alter sodium reabsorption to therefore decrease water reabsorption. So most diuretics will alter sodium reabsorption from the filtrate back into the blood. By doing that, it will also decrease the water reabsorption. So will these diuretics then be increasing or decreasing sodium reabsorption, and why? So again, the action of these diuretics is to decrease sodium reabsorption from the filtrate back into the blood. So the higher the concentration of sodium in the filtrate, the greater the osmotic pressure or gradient of the filtrate, and therefore that will then keep water in the filtrate and prevent it from being reabsorbed from the filtrate back into the blood. And in that way, by inhibiting the reabsorption of sodium from the filtrate, you're going to produce higher volumes of urine. Now, diuretics that inhibit sodium reabsorption are called direct diuretics, and different types of direct diuretics then act upon different parts of the nephron tubules. So can you remember which parts of the nephron reabsorbs sodium? So we're just going to have a look at this on the next slide. Now, in terms of sodium reabsorption, we know that most of it is occurring here in the proximal convoluted tubule. We also know that the descending part of the loop of Henle is not permeable to sodium, so there's no sodium reabsorption occurring down here. But we do know that there's sodium reabsorption occurring here, okay? We also have some sodium reabsorption occurring here in the distal convoluted tubule, and also a little bit in the collecting duct as well. So if we just put in our values here, about 70% of sodium reabsorption occurs in the proximal convoluted tubule. Then when we move down to the ascending part of the loop of Henle, it has a great capacity to reabsorb sodium. Under normal conditions, it will reabsorb 25% of the sodium because most of it has already been reabsorbed up here. But it has a huge capacity to absorb more. And it's here where these loop diuretics that we're going to discuss work. As I mentioned, there is some sodium reabsorption in the distal convoluted tubule, and later on we'll talk about how the thiazide diuretics work here. And then in the collecting duct, about 1 to 2% of sodium, and this is where our aldosterone antagonists work, which are also called potassium-sparing diuretics. So we'll talk about those later too. So with diuretics, as I've mentioned several times now, there are direct diuretics and there are indirect diuretics. We've already spoken about the osmotic diuretics that are used to treat acute renal failure. But with the direct diuretics, there are those ones that manipulate the proximal convoluted tubule, but these are actually very weak direct diuretics. And I want you to think about that now, about why they will be weak diuretics. And I'll take you through that in a minute. Then we also have the loop diuretics, which manipulate the ascending limb of the loop of Henle. And then we also have diuretics that act at the distal convoluted tubule. So in terms of the diuretics that manipulate the proximal convoluted tubule, they are weak for this reason. Okay, so we do know that 70% of sodium is reabsorbed in the proximal convoluted tubule. So and I've just drawn in those ridiculous looking transporters there. Say this is a sodium transporter, right? So let's say you had a diuretic that blocked the reabsorption of sodium from the proximal convoluted tubule. Okay, so that sounds good, doesn't it? All the sodium will stay in the proximal convoluted tubule and water will stay there too. Okay, that sodium then will flow down with the filtrate down the descending part of the loop of Henle and up into the ascending part of the loop of Henle. And we know that sodium reabsorption occurs in the loop of the ascending part of the loop of Henle. We know under normal conditions that it's usually only 25% of that sodium that's reabsorbed. But if you were listening, you would have heard that the ascending part of the loop of Henle has a huge capacity to reabsorb more sodium if necessary. So while you blocked sodium reabsorption up here, it flowed all the way down here into the ascending part of the loop of Henle, and then it's going to be reabsorbed back into the blood anyway because of those transporters there. So that's why the diuretics that manipulate the proximal convoluted tubule are called weak, because the sodium is going to be reabsorbed anyway in further parts or more distal parts of the nephron. So the loop diuretics are the most powerful of all of the diuretics. Some of you may have heard of a loop diuretic called furosemide or furosemide. They do cause torrential urine flow, so they cause the production of high volumes of urine. They act upon the thick ascending limb of the loop of Henle, and they inhibit a sodium carrier in the luminal membrane of the tubule cells. So that's a carrier for sodium, potassium, and chloride. The loop diuretics actually inhibit the chloride part of the carrier, but by inhibiting the chloride part of the carrier, that also inhibits sodium and potassium reabsorption. I think everybody knows what the word lumen means. It just means like the middle or the hollowed out part of a tube. And these loop diuretics can also cause vasodilation, although the mechanism of how this happens is still not really clearly or fully understood. So let's have a bit of a closer look at these loop diuretics, which are acting on this transporter here in the ascending part of the loop of Henle. So if we zoom in a little bit closer, looking at a schematic of the cells lining the walls of the loop of Henle, you can see we have this transporter here that is a co-transporter, and it co-transports chloride, potassium, and sodium out of the filtrate across the walls of across the cells lining the walls into the interstitial fluid and then into a local blood capillary. Okay, so then you're going to give somebody a loop diuretic, and that loop diuretic is going to inhibit the chloride part of that transporter. By inhibiting the chloride part of that transporter, it also inhibits the reabsorption of sodium and chloride from the filtrate back into the blood. Okay, so as a result of that, sodium is going to stay in the filtrate along with potassium and chloride, but that will lead to increased urine output and lower blood volume, so hypovolemia. There's also increased potassium excretion, chloride excretion, magnesium and calcium excretion as well, because magnesium and calcium excretion is linked to potassium excretion. And unfortunately, that's going to lead to, side effects such as osteoporosis. Now, because loop diuretics are so powerful, they're usually only used in situations when a large decrease in blood volume is necessary, or when there's renal impairment limiting the effectiveness of other diuretics. So examples of common use include acute pulmonary edema, to try to shift all of that fluid that's causing the swelling in the lungs, chronic heart failure as well, and renal failure, but not when the renal failure is too severe. And that's because you need some filtrate being formed for the loop diuretic to be able to manipulate it. And in end-stage kidney failure, there's literally no filtrate being produced at all. Now, loop diuretics can also impact upon pH balance. A loop diuretic will cause an increase in free hydrogen secretion into the urine and therefore increase hydrogen secretion in urine. If free hydrogen excretion increases, is body fluid pH likely to increase or decrease? And remember that bicarbonate ion levels will remain the same, but blood volume will be decreased. So the question here is, what effect will that have on pH and why? So if there's excessive or an increase in hydrogen secretion into the filtrate and therefore the urine is going to get more acidic, but the blood is going to get more alkaline. So the pH of the blood is going to increase, and that can lead to metabolic alkalosis. Now, I often get asked, why is there an increase in free hydrogen secretion into the filtrate? So what you have to imagine is that all of these tubule cells have lots of different transporters. Okay, so a loop diuretic will act on the sodium potassium chloride transporter to keep that sodium in the filtrate. But as that filtrate containing that high levels of sodium then flows in an upwards direction through the ascending part of the loop of Henle, it's going to encounter other cells with different types of transporters. And some of these transporters might be a sodium hydrogen exchange transporter. So again, all of that excessive sodium in the filtrate, some of that will be reabsorbed back into the blood via a sodium hydrogen exchange pump, but at the same time that hydrogen then will be pumped or secreted into the filtrate. So just to summarize, loop diuretics can cause a form of alkalosis, metabolic alkalosis, and metabolic alkalosis will impact on electrical signaling of the nervous system and skeletal muscle. It will cause the nervous system to become hyper excitable, where it starts firing off action potentials when it shouldn't. And in severe cases of alkalosis, so remember, alkalosis will get more and more severe as the pH increases, and severe cases then can cause convulsions and death. As I've mentioned, loop diuretics also increase the excretion of other ions, so potassium and chloride, and also calcium and magnesium, because the transport of these two ions is also linked to the transport of potassium. Loop diuretics will also decrease the excretion of uric acid. So less uric acid being excreted means more uric acid in the blood. Abnormally high levels of uric acid in the blood is called hyperuricemia, and that uric acid can precipitate out of solution and then lodge in joints to stimulate inflammation and cause gouty pain. In terms of loop diuretics pharmacokinetics, these are usually given orally. They're readily absorbed across the GI tract and they act within about an hour. They can, however, be given intravenously if you need a quicker effect, and in this mode of administration they act within 30 minutes. You would give it IV for severe cases where you need to shift a lot of fluid really quickly, or when GI absorption is impaired. So you wouldn't be able to give an oral tablet in that case, so then a person might be given it IV. For example, impaired intestinal perfusion, so if there's a lack of blood flow to the intestines, in congestive heart failure. And the reason you would be giving the loop diuretic to begin with is to treat the congestive heart failure. But if you've got impaired intestinal perfusion, that's why you'd need to be giving it IV mode instead. Now, loop diuretics don't pass through the glomerular filtration membrane, so they're not filtered. But to act upon the luminal membrane of the ascending limb cells, the drug must enter the lumen tubule. So how do you think the drug gets into the tubule lumen? So I think everybody will be getting this correct as well. It's via tubular secretion into the filtrate. Since most of the loop diuretic will pass into the tubule lumen, how is the majority of loop diuretic removed from the body? So the majority will be active drug, and it will be excreted as active drug in the urine. However, the portion of loop diuretic that remains in the bloodstream will be metabolized. And a very easy question here is, in which organ of the body does this metabolism occur? Of course, it's the liver, and those inactive metabolites then are also excreted in urine. Now, just to summarize some of these unwanted effects of loop diuretics, frequent urination, I guess, that's why they're prescribed, but they do cause torrential volumes or really high volumes of urine. Too much loss of sodium and therefore water can cause hypovolemia and therefore hypotension. There might be too much loss of potassium. So too much potassium getting lost in the urine then will cause hypokalemia. And this creates problems, particularly if the person taking the loop diuretic is also taking another drug, say like a cardiac glycoside such as digoxin, because hypokalemia then will increase the effects and toxicity of other drugs that the patient may be taking. So digoxin, which we will study in the cardiac topic, it treats cardiac arrhythmias, so it's an antidysrhythmic drug. And it will compete with potassium for binding to the part of the sodium potassium pump. Okay, but here you've got somebody who's taking a loop diuretic and they're losing too much potassium from the blood, so they've got hypokalemia. So there's going to be less potassium to compete with the digoxin for the receptor on the pump. So digoxin can happily bind to it, and so that's going to increase the effects of the digoxin and also the toxicity of the digoxin. Loop diuretics can also cause alkalosis, as I've previously described, and also gout, as we've talked about before too. So if there's insufficient secretion of uric acid into the filtrate, that will cause abnormally high levels of it in the blood to cause hyperuricemia. Those uric acid crystals then will form, particularly in peripheral joints, and that will stimulate inflammation and gout and that gouty pain. Prolonged use of loop diuretics, particularly in older people, will increase the risk of osteoporosis. And that's because, calcium transport is linked to potassium transport. So with using a loop diuretic, if you're inhibiting the reabsorption of potassium from the filtrate into the blood, you're also going to inhibit calcium reabsorption. So calcium is going to be lost in the urine as well, and that can therefore increase the risk of osteoporosis, which older people are already at risk of developing anyway. And finally, there is an unwanted effect that thankfully is very rare, and that is hearing loss. And this is because the same transporter, a sodium potassium chloride transporter, is also present in the inner ear. Now, the loop diuretics do accumulate much more within the nephron tubule compared to the inner ear. So usually the dose within the ear is not high enough to cause problems. However, if somebody is taking multiple drugs and there are drug-drug interactions that cause the loop diuretic to be at a greater concentration in the blood compared to what you want it to be, then this risk of hearing loss increases. Or if somebody has kidney impairment, which increases the half-life of a drug and also the concentration of it in the blood, then that can also increase the risk of hearing loss. And so I guess this just does highlight that both the actions of a drug and where the drug will accumulate in the body is important.